Good day. We will be discussing regarding ideal ERCP steps. So our main focus will be regarding a simple CBD stone case because that will demonstrate regarding each of the steps of ERCP. So actually this video PPT is done for the benefit of mainly technicians and young endoscopists to understand how a technician should work outside the scope and an endoscopist how he should coordinate with a technician, because a complete ERCP happens only with the teamwork between the technician and the endoscopist. And the purpose of making this recording is that today we had the ERCP candidate conference, which we had targeted a pan India conference, which in our GEM Hospital Chennai, targeting the technicians. So after I had presented this in the conference, many technicians they asked me personally to kindly please release the PPTs. So it was a video PPT which I had used. So what I thought is I will add my descriptions also. So it will help each of you, young endoscopists as well as technicians, to know what are the ideal steps so that you can start practicing it better in your practice. Position, the best position for a simple CBD stone case will be a prone position because the ambula can be stable in position. Left lateral position can also be used by keeping a pillow under or a semi-prone position. Supine is used in 10 societies, cardiac failure or pregnant women. But supine position is tricky because the ambula positioning will be very much troubled in supine position. You may need a few more maneuvering. Most common is the prone position. And minimum equipments and required, make sure that these equipments are kept ready before you start the procedure. Sphincterotomes are different types of sphincterotome. Most commonly used is pull type sphincterotome. A push type sphincterotome can be used in altered anatomies, but most commonly you use a double domain pull type sphincterotome. Guide wires also, different guide wires are there. For a simple CBD stone case, a hybrid wire alone is more than enough. Hybrid wire will have the tip as hydrophilic and rest will be non-hydrophilic. That is more than enough for a simple CBD stone case, so that exchange of the hybrid wire or the guide wire is not required. But institution to institution it changes. In my institution, we follow first fully hydrophilic wire followed by hybrid wire is the protocol that we follow. Agents used for contrast should be kept ready. Inoxol will be used in ratio of 1 is to 4 or 1 is to 3, that is 25 to 50% will be used. For small CBD stone cases, use diluted ones, so that like 25% or 30% diluted ones, so that small stones are not missed out. Normal saline should be kept ready. Balloons for balloon rolling should be kept ready. Stents of different size should be kept ready, so that as the endoscopist asks, the technician should be able to hand over it. And stent pushers should be kept ready, and electrocoated devices should be checked and kept ready. The most important thing that you should make sure these equipments are working, so that after you put into the ERCP channel, you do not encounter troubles. Coming to the first step of the procedure, the first step of the procedure is a side viewing scopy. Important thing about side viewing scopy is that it has a major role to be played by the endoscopist. But sometimes the technician's role comes when you want to give an abdominal pressure or you want to change the patient to a left lateral position. After you reach the deep D2, you'll have to reduce the scope so that you position the ampulla in position. So here, both people, both endoscopists as well as technician has a role. Technician will have to sometimes give abdominal pressures in prone position by putting the hands underneath. If you feel intubating into the D1 is difficult, or left lateral position or a semi-prone position by keeping a pillow down should be sometimes required. Positioning the ambula in place and keeping it in stable position is very important, and that is a role to be played by the technician so that the scope do not skip off. The next step what comes into an ERCP procedure is regarding CBD cannulation. So regarding CBD cannulation, what you should understand is that CBD cannulation is most key procedure. So what we tell is that before you attempt to cannulate into the CBD, you must make sure you identify the CBD properly, position it properly in the center or in the right left upper quadrant before you attempt to cannulate. And the direction of cannulation will be in the 11 o'clock to 1 o'clock direction. And when you are cannulating it into the CBD, regarding the technician, the sphincterotome, bowing the sphincterotome should be in proper adequate manner. It should not be too much or too less. You should coordinate it with the consultant or with the doctor so that you do not bow too much. How to bow it, how to further introduce inside will be decided by the endoscopist based on the anatomy. Second thing is, while you're pushing inside, do not push if you have a resistance. Especially while pushing the guide wire, do not push the guide wire further if you feel resistance. And once you have engaged it, aspirate the bile to confirm it in CBD. And withdraw back if any resistance is there. In between, use fluoro check scope. So from a technician point of view, the most important thing is bow adequately. Do not bow until the endoscopist asks you. Second, do not push the guide wire too much. If you push it too much, it will just go and hinge in the wall if or the stone or strictures. Another step is cholangiogram. Cholangiogram, after you have accessed the CBD axis, cholangiogram is performed to see, to visualize the CBD diameter, size, and number of stones. So the dye which you have already diluted and kept, make sure that air is being removed before you inject into it so that air do not cause artifacts. And when you are injecting, while injecting it inside, you should coordinate it with your endoscopist so that your endoscopist will be doing cholangiogram from proximal to distal one. So you can see in this video the technician injecting the cholangiogram and the endoscopist is visualizing. And sometimes we will have to pull it down. So they pull it out so that we can see the distalmost part of the CBD also. You should coordinate it with your endoscopist while you are pushing the contrast agent. After cholangiogram is being performed, you have to do a sphincterotomy. The sphincterotomy is done in 11 o'clock to 12 o'clock position. Even while doing a sphincterotomy, most important thing is that don't bow too much. If you bow too much, there can be Zyber cut effect will be there. Also, while regarding the wire which is in contact with the tissue, make sure only adequate wire is in contact with the tissue. If too much wire is in contact with the tissue, also cut might not work properly. Or if too little is also in contact, it can be extensive cut or deep cuts might not happen. So adequate amount of tissue only should be happen. That happens come from the experience of the endoscopist. From a technician point of view, your role is you should not bow too much unless your endoscopist asks you for. And while using the airway electrocautery system, the mode which you should use is in airway, new generation airway electrocautery devices, there is Q cut mode. There are I type and Q type endocut modes are there. Endocut I is commonly used. Or if you are a beginner, if you need, the endoscopist can even use an Q type. So I type or Q type, endocut I or Q, whatever you are using, most commonly I type. Most important thing is the yellow pedal or the cut pedal, you should continuously press. You should not cut coagulate, or cut release. You should not do that. You just continuously press the yellow pedal. The machine will auto process it and do the cycles of cut, coagulate, and pause. The next step is, we have already kept an hydrophilic guide wire inside. Now we'll have to remove the hydrophilic wire and put an hybrid wire inside. So exchanging the hybrid wire is the next step. So you remove the hybrid wire which is put inside, and you will have to insert a remove the hydrophilic wire which is put inside, and you will have to insert a hybrid wire. And what you can see my technician performing is she is inserting the hybrid wire inside. So she is advancing the hybrid wire in coordination with the endoscopist. Endoscopist's role is he will make sure that the axis is not being lost. The sphincterotomy axis is not being lost while she is advancing the hybrid wire inside. Next is we will have to remove the catheter. So before removing the catheter, what we have to do is we have to flush the catheter with the sphincterotomy catheter with some normal saline. So because the contrast agent which is thick would have been inside, it should be washed off before you pull it outside. Next step, you will be removing the sphincterotomy outside, and you will be advancing a balloon catheter inside. So the next step is you will have to remove the sphincterotomy, and you will have to exchange. You will have to insert a balloon catheter. After removing the sphincterotomy, what you see now is the endoscopic technician is trying to advance inside the balloon catheter. So when the balloon catheter is going inside, what you can see in the video is that the guide wire remains stable. So this work is done by the endoscopist. He will double lock it. One, he will hold it properly, and he will keep the elevator up so that the guide wire is stable. And the endoscopist, the technician will give adequate traction, so that she will only give adequate traction while she is pushing inside, so that the wire doesn't slip off. So that step is very important. Now you can visualize this is just replaying the video again. You can visualize she going inside, and now when the endoscopist is pushing inside, you can see that she's giving adequate traction so that the wire doesn't slips off. So this is a coordinated work between the technician and the endoscopist so that the wire doesn't slip off. Now in the video, what you can see in the PIP view is that you can see the balloon catheter coming outside, the endoscopist maneuvers it and pushes it inside. The next is balloon stone extraction. So before you advance this balloon inside, you should just verify that the balloon is working. After that, advance the balloon inside. Advance the uninflated balloon distal to the stone. So you check it with the C-arm. After that, you have to inflate the balloon and then balloon sweep it. And once you balloon sweep it, you can see the endoscope is pulling out the balloon out. So here, the technician's role is in the first step, the technician's role is to check that the balloon is working. Once the balloon is working, deflate it, and the endoscopist will be advancing it further. In all these steps, make sure the guide wire doesn't slips out. And after that, again the technician will be, when the endoscopist the technician again inflates the balloon. This will be coordinated with the C-arm image. So you can see the roles which I have put: first technician, second technician, endoscopist. And then he will be pulling it out and sweep the stone outside to extract the stone. So there should be a coordination between the technician and the endoscopist to have a successful balloon sweeping again. So once the balloon sweeping has been done, you will have to do a check cholangiogram. Check occlusion cholangiogram, the same balloon can be used for doing a check occlusion cholangiogram. You can do it from proximal end to the distal end. You can advance it up, inject the balloon and coordinate it with the endoscopist, and the endoscopist will be pulling it out, and the technician will be injecting the contrast agent, and seeing the check cholangiograms will be seen in between to see if there are any remnant stones or not. Till distally, the same procedure will be repeated. Now we have to remove this balloon catheter. So while removing this balloon catheter, you must see the movements in the endoscopist's hand as well as the technician's hand. You can see that it's a coordinated movement between the endoscopist and the technician. What the endoscopist does is he will be pulling it out, when at that time she will be giving an adequate traction push inside. So she pushes the guide wire inside, he pulls the catheter outside. So it is a coordinated movement. Second thing is that, see, he double locks it. He holds the guide wire with his fingers, as well as he keeps the elevator up so that the guide wire doesn't comes out. Even this double locking system on holding the guide wire with the elevator up can be done even when in the initial steps. So I'm just replaying it again. So he is pulling it outside. Now the catheter has come inside the scope. From this time, you can keep the elevator up, and she will be pushing the guide wire and he will be pulling it. So it's a coordinated movement so that the guide wire doesn't slips out. You can see the technician's hand movements. So she meticulously pulls it out and she takes it out without slipping the guide wire, and she will be meticulously taking the catheter outside from the guide wire, holding the guide wire in one hand and the catheter in other hand, and rolling the guide wire. These are important movements that should be coordinated between the technician and endoscopist, so that while taking the balloon catheter outside, you do not slip off and lose the access. Same thing is while taking any devices outside. The final and the most important step is stenting. So while putting the stent, you must make sure that the guide wire doesn't move, and you have kept the guide wire locked by keeping the elevator in the locked position. So she will be inserting the stent inside, and the stent pusher is being now inserted inside. So first the stent, the smaller end of the stent, then the stent pusher, she is inserting the stent pusher. So the technician's role is to give adequate traction, and the endoscopist's role is to push the stent pusher inside, so that you will find the stent coming out through the working channel. So once you feel that the stent hits the elevator, you should release the elevator, and the stent is being deployed inside by maneuvering it by using the up wheel and the elevator and the scope movement. You are maneuvering the stent inside the CBD, and the technician and the endoscopist should coordinate for releasing. While releasing, she pulls off the guide wire and he will pull the pusher out. And finally, the pusher is being fully pulled out and stent is being released. So again, it is a coordinated movement. Once you have confirmed it, you will have to recheck it by doing a C-arm. So that completes the final steps of ERCP. So it's again a coordinated movement. What you have to know is that you will have to know each of your role, do it in a coordinated manner. See the video again so that you can understand how each step works. So this completes a complete procedure of an ERCP for a simple stone case. Finally, post procedure, make sure you monitor the patient for if there are any complications or not, at least for the next 2 to 3 hours, and after which you can discharge the patient if it is a day care procedure. Finally, the most important step is teamwork. Again, I tell you, it's a teamwork between endoscopist, ERCP technician, anesthesia team, and the full team. So, educate, empower your team. You share this video with your co technicians or endoscopists so that you can grow in knowledge and have a wonderful experience performing ERCP. Thank you.